Hereby, I open this academic ceremony in which Priscilla Attafuah will defend the academic thesis, Quality of Life, Health and Social Needs of Slum-Dwelling Older Adults in Ghana. May I invite you to present a summary of your studies and the conclusion of your thesis.
Thank you, Prorector. Dear friends, family, dear assessment coroner, dear supervisors, thank you for taking time to listen to my thesis titled Quality of Life, Health, Social Needs of Slum-Dwelling Older Adults in Ghana. The study was carried out in Ghana, which is in West Africa. Ghana is a very beautiful country with our capital city, Accra. Predominantly, Ghana is divided into two communities, the urban and the rural settings. Considering the resources available in the rural settings, most people migrate to the urban areas in search for greener pastures and also in search for jobs. So on the upper right, you can see a picture of Ghana at daytime, the urban settings, and then the rural setting also. Beneath is a picture of Accra at night. Their migration leads to formation of slums. Slums are characterized by pollution, violence, poor drainage systems, improper disposal of waste, improper housing, and absence of easily accessible potable water. Considering the vulnerability of older adults, being exposed to pollution, insecurity, and the risk for infection, it's not the best for older adults living in slums. Life expectancy is improving globally, and the quality of these lives should, however, not be overlooked. Developing countries like Ghana have not been left out of the increasing life expectancy, with its current age of 64 years. For this dissertation, older adults are characterized as people 60 years and above. Using the WHO definition of quality of life as an individual's perception of their position in life in the context of the culture and value systems in which they live, and concerning their goals, expectations, standards, and concern. Quality of life is subjective and is a multidimensional concept which can be influenced by the health and social care needs. Hence, it is important to consider this phenomena in the vulnerable populations such as older adults in slums. The main objective for this dissertation is to assess the quality of life of older adults living in slums, including their health and social care needs, both from the perspective of slum dwellers and then care professionals. 5 studies in all were carried out for this dissertation using different methodologies, and all these have been published. In the first study, we looked at a scoping review which aimed to identify instruments that are available for assessing quality of life among older adults in African countries. Using the inclusion and exclusion criteria, which included the use of generic quality of life instruments in the studies retrieved, and also looking at publications that were written in English, to mention a few. We reviewed in all 18 studies, which came out with 7 unique instruments with little information on psychometric properties. These included the EuroHIS Quality of Life, the WHO Quality of Life brief version, the Satisfaction with Life Scale, the WHO Quality of Life, the old version, short form 36, short form 12, and the RAND 36, which is also the short form 36 version used in South Africa. For the second study, we looked at the quality of life of older adults in slums, assessing their quality of life of these population in 2 slums using the Huko brief. We used a community-based cross-sectional design and had a total of 400 participants, 60 years and above, and 397 were analyzed. The findings showed that the older adults in these slums had moderate level of quality of life in their psychological, their social, and environmental domains. However, there was a poor level of physical quality of life for older adults in the slums. We also realized that males had a better quality of life on all domains compared to their female counterparts. Additionally, the environmental domain had the strongest influence on quality of life after a regression analysis was done. We went on to have the third study, which was health and social needs from the perspective of older adults. The aim was to explore the self-perceived health and social needs of older adults in urban slums in Ghana. We used the phenomenological approach and had 25 semi-structured interviews from the period May to June 2021. Considering the slums, we moved house to house at Teshi Mami and then Ashaman. The main themes that came out were perception of health, the demotivators or motivators of health service use, the perception of social care of these older adults, their social needs, and the influence of the phenomena on quality of life. Findings from this qualitative study showed that most older adults had one or more disease conditions, which confirmed their poor quality of life in the second study. However, despite their rather ill health, various participants believed that their health conditions were either caused by witchcraft or evil spirits, which negatively influenced their use of formal health services. Additionally, they had many unmet social needs, which they identified as a sense of neglect by family members, as they desired companionship and also required assistance in performing activities of daily living. They also complained about the need for financial support, as most of them either did menial jobs or were not working. The fourth study looked at improving health and social care for slum-dwelling older adults, looking at the perspective of health professionals. We explored the views of these health professionals and also sought recommendations for improving access to health and social care services among slum-dwelling older adults. The main themes for this were utilization of healthcare services, access to social services, and then their recommendations for improvement. The healthcare professionals confirmed that older adults had financial difficulties. Hence, this was a barrier to them accessing healthcare services. Additionally, queuing issues at the various health facilities was also noted as a barrier. Distance to health facilities, their health literacy, and the negative attitude of some health professionals were also identified. For the social care services, health professionals mentioned that they were either non-existent or non-structured, and also some had limited resources to cater for attendance of these social care services. They recommended, however, that pre- and post-training of nurses should be taken up, where nurses in training before they pass out are given better training, better education on who older adults are and how to take care of them to the best of their abilities. Additionally, they recommended that nurses in practice should have regular webinars, workshops to help educate them better. They further went on the National Health Insurance Policy to advocate that instead of having a National Health Insurance Policy which caters for older adults 70 years and above free access to health care, it should rather be reduced to 60 years, considering that the life expectancy of older adults in Ghana is 64 years. They also recommended government supports for available daycare centers and advocated for a liaison between NGOs and governments to better propagate their activities. They also mentioned that health promotion activities on the part of health professionals towards these older adults living in slums will help improve their health and social care. For the final study, we looked at student nurses' perception and attitude towards care of older adults. We aimed to explore their perception and their attitude and also seek their impressions on career goals in the area of geriatric nursing. For analysis, their perception, attitude, and career progression, conclusion was that students perceived older adults by their chronological age, and they categorized them also by their physical appearance. They saw older adults to always be depressed and are always complaining and uncooperative when they are taking care of them. On their attitude, students generally had a positive attitude to caring for older adults because they saw them as their grandparents, and they also saw it as an opportunity to learn how to take care of their own parents should they grow old. They viewed registered nurses as being rude or unkind to older adults and felt this wasn't important or needed at this point in their lives. However, most students who took part in this study would not want to pursue a career in geriatric nursing because they felt they did not have the needed skills and knowledge to be able to do that. And they also mentioned that they required a lot of patience, which they felt they hadn't garnered at that stage. Overall, this dissertation established that older adults living in slums had a moderate overall quality of life and were dealing with various health and social challenges, including national health insurance challenges, queuing issues, distance to health facilities, their health illiteracy, and their issue of loneliness. This dissertation also highlights the views of student nurses who are expected to take over the care of older adults after training. And it was discovered that the passion to care for older adults is absent in most students. To borrow the words of Jenna Dillon, we have to keep educating and enforcing in every way we can, including litigation as a last resort. Practical implications for this dissertation. Considering the poor physical quality of life of these older adults, health professionals can, by this study, provide better services, patient-centered care services to these older adults and meet them at their doorstep if possible. The issue of health promotion and awareness creation is very much needed in the Ghanaian community at large and especially amongst older adults and their caregivers in slums. Older adults in slums desire the company of friends and family. So although the Ghanaian setup is family-oriented, we can do better. Additionally, enhanced regular home visits by healthcare professionals can help improve the company of these older adults as well as provide better healthcare services to them. Lastly, we advocate for care navigation in health facilities to minimize queuing issues and also help them to move through the various segments in the hospital or health institution. Our recommendations for future research would ask for the need for more in-depth research on the content and domains of instruments used in accessing quality of life among older adults, especially in African slum settings. Again, intervention studies on care navigation of older adults in health facilities is recommended. Lastly, interventions to stimulate and educate healthcare professionals so that they can take better care of slum-dwelling older adults is recommended. Having lived with my grandma close to the slum myself, this is my little I can do for the people of Teshi. Dank u wel, thank you, medase, medabushi. Over to you, Director.
Dank u wel. Thank you very much for your presentation. We now start with the opposition. And the first opponent is Professor Pavlova, Professor of Health, Economics and Equity at Maastricht University.
Thank you. Dear candidate, my congratulations to you and to your supervisory team for this important dissertation, which is focused on quality of life and social needs of older adults living in the slums in Ghana. The topic is highly relevant and has important implications for policy and for research. Evidence that you provide will be important in future policy on long-term care in Ghana, but I'm sure that also researchers and decision makers in other countries in the region can benefit from this study and because it provides some important issues on the increasingly important topic of long-term care in Ghana and in African region. The 5 studies in your dissertations are well taught, and they are well linked to the overall topic of the dissertation, and all of them, as understood now, are already published, which is also an indication of quality of the research that you have presented in the dissertation. But having said that, I also have some critical questions, which I would like to discuss with you today. And some of these questions, they refer to chapter 3 in the dissertation, which presents a cross-sectional study results. In this chapter, you are using as your research instrument a questionnaire which is developed by WHO. We also have seen that this is your choice is based on the literature review that you have done before this study, and you are also critical about that questionnaire in chapter 3. Myself, I also have some doubts about using such general question developed by international organization and applying it to a specific setting. So I was wondering to what extent the research instrument actually fits the context of your study. And specifically, what kinds of measures did you implement in order to make sure that the research instrument, the WHO questionnaire, actually fits your study context?
Thank you very much, highly esteemed opponents, for your compliments and also for your question. To what extent it fits from our initial study, which was the scoping review, we sought to identify instruments that assess generally. At the end, we were not looking for, it was difficult to find a most suitable instrument, but we realized that the WHO quality of life breath had been used in one slum setting, and that was why we settled for that questionnaire. Additionally, we agreed that some content of the WHO brief may not suit the slum setting. There were questions about how to climb stairs and how the person feels. Yes, that will definitely not translate into the slum setting. So some questions were adapted. We also did a translation and back translation so that we could ask the questions to the best understanding of the participants. Thank you.
Okay, thank you for this clarification. So it's nice to hear that your research instrument has been also adapted to the research setting, and so it's a valid instrument in that setting. Let's look now a little bit at the analysis that you present in that chapter, and specifically using both ANOVA method and regression analysis. This is a bit repetitive, I would say. Usually we will just have either ANOVA regression or regression analysis. So why you thought that regression only is not sufficient? What was the purpose? What was the added value of having both analysis?
Thank you. We had both analysis done. The ANOVA was to compare the gender and those that were 2 teams. However, we used the regression analysis to compare how the various domains, how the demographics affect the various domains of the quality of life breath. That was why we did both.
Okay, thank you. And I wonder, in this study, you probably you are not able to capture all the factors as independent variables. Which were the factors that you are not able to include in the analysis, which you thought is really relevant, but I do not have the possibility to ask those kind of questions. I do not have a possibility to get this kind of information.
Thank you. After reading through the quality of life breath, there were questions on the sex of participants, and this is a subject that is usually not welcomed in our setting, in the Ghanaian settings, and also with older adults. So we couldn't do much about this aspect of their quality of life. Thank you.
And what about children? For example, with more and more children, they start living far away from the parents. So would that be also, that is also an issue also in Ghana? Was that also a relevant issue for the study setting that you explore?
Thank you. For the aspect of children, most children lived in the homes with the older adults. However, they only went out of the slums to work, so they came back in the end. That is how come in the third study on their health and social needs in their perspective, the older adults did not have so much issue with their social care needs because they had the familial system around them. So that wasn't a problem in our setting.
So in another setting, that could be also...
Yes, that could be a setting, yeah.
Okay, thank you for this discussion. I give back the word to the prorector.
Thank you very much, Professor Pavlova. Then the next opponent is Professor Joosen. He's Professor of Community Health at the University of Ghana in Accra, Ghana. Welcome.
Thank you. Thank you, Priscilla and the supervisory team for such a research in a very important area, especially in our setting in Ghana, quality of life, health and social needs of older adults dwelling in the slums, especially when Ghana, in terms of sub-Saharan Africa, has one of the highest proportion of older adults per capita, yes. So it's very important, and as we move towards the achievement of universal health coverage, our system is quite weak in terms of geriatric and palliative care. So this has both practical, scientific, and policy implications. So well done.
Thank you.
I have a few questions to ask you to explain further on. In chapter 3, it borders on chapter 3 mainly, you indicated that older adults, the quality of life of older adults in the slum-dwelling areas were moderate. One would have expected especially their psychological and mental states to be much worse, considering that in our context, formal social support system is very limited. What probably could be accounting for this in terms of informal caregiving?
Thank you very much, highly esteemed opponent, for your compliments as well as your question. We were also surprised about the findings after analysis because from the onset, we hypothesized that older adults living in slums would have poor quality of life generally. However, from domain by domain, we realized that the psychological domain has influence on their quality of life. Nonetheless, their family setting and then the relationship they had with their family and friends around could have buffered this finding, and then they had the moderate quality of life. Additionally, they could also be coping with the circumstances they find themselves, so they would not let it affect them so much compared to someone who originally lived in a non-slum and now is going to live in a slum. Thank you.
Okay. So related to that, you also found that the males rated their quality of life higher relative to the females. Is there any medical, sociological reasons that you can think of this in our context?
Thank you. In the Ghanaian setting, not only to the slums, men in general always want to act they're strong and will not want to seek help if they have a problem, because it shows a sign of weakness. So if you ask a male questions about their quality of life, there's the tendency for them to answer with all alacrity that I am fine, even when they are not fine. So this could also influence why males appeared to have a better quality of life than their female counterparts.
Okay. So masculinic hegemony, isn't it? The other one borders more on the technical aspects also of the chapter 3. This is a survey that you did, but you indicated that the key informant used a convenient sampling method to select participants and then use snowballing technique. So generally for a quantitative assessment like this, where you are going to use parametric methods, you did ANOVA, you did regression. To what extent do you think the convenient sampling could affect your results?
Thank you. Yes, we also thought through this. Considering the slum setting, it was difficult to have a random sampling method in the slums to choose participants. Additionally, the key informant knew better the mapping of the houses. So he could send us to one house, and then someone from that house directs us to the next house with the older adults. Though snowballing is usually done for qualitative studies, there have also been studies where, because of restriction of the settings, snowballing had been used for quantitative studies. So we are sure this will not affect the results despite us using the convenient sampling. Thank you.
So is there anything you did in your work that made you comfortable that this will not affect it?
Yes, we tried to map up so that we don't attend to the same person after going round. Though there were various people collecting the data, we tried to limit the bias of going back to the same person for the same data. Yeah.
And your sample size?
Sample size was quite large, yes, so that's also covered for it.
Thank you. You had a sample size of over
400, yes, and on analysis we used 397 because some of them did not know their ages or their years, so when they wrote the year, we calculated and realized they did not fall in the category, so that is how come 3 were taken out. Thank you.
Thank you very much. Back to the
Thank you very much, Professor Joosen. The next opponent is Professor Cardol, Professor of Active Aging at the Free University of Brussels.
Thank you. First of all, I would like to compliment you on your thesis. I think the subject of your study and your involvement with the target group alone may contribute to the realization of your ambitions. My compliments also go out to your supervisors and co-supervisors. On page 14, you projected a bridge, and I think they cooperate with building the bridge from Accra to Maastricht. You explored your research question in depth, not only theoretical, but also in the field, and you turned it into a dissertation worth reading. Before I question you about the content of your thesis, I will read out your second proposition. A positive change in the environmental domain may increase the quality of life of older adults living in slums in Ghana. And my question is divided in 2 parts. Okay. First one, is improving housing and living conditions by the government not the highest priority? And are health and social needs not derived from this? And the second part is, if that were the highest priority, wouldn't the willingness of nurses and student nurses follow automatically to support the needs of the elderly living in the slums?
Thank you very much, highly esteemed opponents, for your compliments and also for your question. If I may take the first bit on whether housing is a priority. Housing is a priority for the government. However, the problem is affordable housing. There may be houses built by the government, but they may not be affordable to these older adults living in slums. Their health and social care needs are of priority to the older adults themselves. We agree that should they be in better houses, their health and social care needs might improve. However, we also admit that older adults living in these slums will, for one reason or the other, per other studies carried out, not agree to move out of the slums and would prefer to stay where they are and adapt or cope with their situations. So their health and social care needs may still be present because of their housing structures or their environmental components, and hence we would have to tackle it from the point of what their health and social care needs are, and not solely their issue of housing. On the second bit about if their housing is improved, the attitude and perception of students and nurses will automatically be affected. Well, would say yes and no, because if housing is improved, it gives you a better image of yourself, and then when they attend or visit health institutions, they will be better received. Nonetheless, as nurses, we've been taught that do not use the creed, color, or looks of somebody to take care of them. So irrespective of where they live, we would expect that these students, nurses will attend to these older adults and not only consider them coming from the slum, so you look down on them, but to take care of everybody holistically. Thank you.
Thank you for your answer. Thank you. No further questions. Thank you.
Thank you very much, Professor Cardol. The next opponent is Professor De Vries, Professor of Health Promotion at Maastricht University.
Yes, thank you very much. Well, let me also compliment you, but I'll do that shortly. I also like the illustrations that you did. The bridge is a photograph, and then later there are small drawings. Did you do them yourself?
No, please.
No, I thought so.
But they all had meanings.
They all have meanings. I saw that. I saw masks, and I saw COVID coming up. Although at chapter 4 and 5 you omit them. I was really disappointed that there were no illustrations at the beginning of that. But of course, you know, I'm impressed by the work, also the general CV that you presented at the end of the book. You did a lot of work, not only in this thesis, but also in the rest of your professional life. But let's now turn to the more important questions. My first question is a very general one, which is there something special about the elderly in their situations? Because if I look at the results of your study, this might maybe also apply to, let's say, working young adults, younger adults, so under 60s. So is there something special, and could you tell me why you think this is so?
Thank you very much, highly esteemed opponents, for your compliments as well as your question. Yes, I have a special spot for older adults, probably because I lived with my grandmother, who lived close to the slum, one of the slums I worked in, and she lived to be 102. So having watched her till her death, I feel we could do better for older adults who lived around her. They did not have the best of sanity, but they managed and coped. So I felt bringing a scientific evidence in that area would be more forceful in directing policies to improve their quality of life.
But just to press on, because the younger people also have problems in sanitation or in water supply or in, well, even in work, and they have the same environmental needs probably than the older ones would have. So again, I mean, I respect your personal experience, of course, but is there something special about being old in the slum?
Okay, so older adults generally have a lower immunity level, so having all this pollution around them is not healthy for them. Additionally, if there should be an outbreak of fire, mobility issues would not let an older adult move about fast compared to the younger ones. So the younger ones have more advantage comparatively to older adults in the slums. Yeah.
But okay, so there are some special needs. You also put a wheelchair somewhere, and so this connects to this answer. So thank you. I would also like to go back to something that has already been addressed, I think, which is about the gender effect in quality of life. because the males report higher quality of life, but the males are also younger, because the women tend to live longer. So might this not be a reasonable statistical or epidemiological explanation for this difference?
Thank you. Yes, it could be. However, having worked in the healthcare setting and then receiving and attending to older adults, sometimes after individual, would I call them interviews or conversations with them, I realized that some older men may have hidden their conditions for a while, and they only come to the health facility when they feel it's gotten worse. Okay. So that is when they seek care.
But statistically, and I think we talked about that when I read the first draft of your manuscript, because again here you do sort of a bivariate analysis in which you relate gender or sex to quality of life, whereas if you would do a multivariate analysis in which you also include age as a covariate, then you could rule out my previous explanation. Yeah. I'm very happy that you redid some of the analyses. I mean, I think that is really commendable, and also not nice, of course, if a reference says maybe you should do something a bit differently. But well, you could rule out. Also, I was a bit curious because, of course, you do the snowball sampling, but there's a wide discrepancy in the gender, in the genders in both slums. So, on page 49, I think, it appears that 21% in Teshi is male, and so there's 78% that is female, whereas in Ashaman it's the reverse. It's 57 against 42. How come this difference?
Thank you very much. Considering the data we collected, probably we met more females in Ashaman because Ashaman being close to the industrial city Tema in Ghana, most of these males may have gone to work at the time of data collection, and the females were available. It's likely that is why we had more females in Ashama compared to the Teshi.
And Teshi is a fisherman's community?
Yes, it's mainly fishing. And the fishermen are close to home, so it's easy to spot them.
Oh, I thought maybe they also fish at night.
Yeah.
So then they would be available during daytime.
Daytime, yes.
Okay, so thank you for enlightening me here. Now, you address needs, and the needs are derived from the WHO Quality of Life instrument. Now, you know, I like theory, and there's one theory about human needs, which is the Maslow theory. Are you familiar with Maslow? And it's a hierarchy. And that's also, I think, related to something that Professor Cadol asked, because the hierarchy model says something like, if you don't have the physiological needs satisfied, you won't get to the psychological or social needs, or because that is the hierarchy in there. So do you have any ideas about the applicability of Maslow's theory in the slums? Because that would boil down to indeed addressing first, you know, the very basic needs. Well, so I'd like to see your
Thank
reaction.
you very much. Yes, this was outside the scope of our study. However, in my opinion, Maslow's hierarchy of needs is very important in everyday life, and it is important in the slums also. So yes, if we meet their basic physiological needs, we definitely would expect them to have a better self-esteem, better self-actualization as they go across the band. Yeah.
But you did not see anything, or let's say the general, in general, the basic needs are not met.
In general, probably it was also because of the tool we used in assessment. So probably for further research, we could look at that later.
You would take another instrument than the WHO Quality of Life, Well, I think that would be important. I also would like to see if you press on in new research, because you use the WHO definition of health, it originates from 48. And of course, especially here in the Netherlands, we are very fond of a new definition of health. Have you ever heard of positive health as a concept?
No, please.
Okay. So this is there is a publication in New England Journal of Medicine, I think, about this new definition, which says that health is being able to cope with the challenges that life puts upon you, which might, in slums, be very, very relevant, I think. And then, if you go on in that, then there would be 6 dimensions in health that are very important, which are the bodily functions, mental health, mental well-being, meaningfulness in life. So having seeing yourself as an important person, quality of life in general, participation, which might be very important also in slums, I think, and especially also for the elderly who are treated as seniors and wise people, I think, and daily functioning. So now I know that it's very difficult to ask you to reflect on this, but don't you think it might be important to see that new definition and to address it in new studies?
Thank you very much. Yes, I think this is a new definition that is worthy of consideration. Considering I also teach Introduction to Community Health, where we look at the definition of health by WHO and also critique it. So this is a new dimension I could read on. Thank you.
Let's work together on this. Sure. I'm a health promoter. Can I still go on? I'm a health promoter, and in the last empirical chapter, you say it's important to develop health promotion activities. Which health promotion activities would these be?
Thank you very much. Mainly for our findings, we realized that the health education component of health promotion is necessary for these older adults and their caregivers. In the same vein, I have registered an NGO, a non-governmental organization, which would look up to educating of older adults and then health professionals as well as their informal caregivers, so that we can educate them on what aging is about, what the older adults need, and how to treat them holistically and also with respect. Thank you.
Yeah. Okay. I think I have to stop here, but thank you very much for your answers, and I'll give the word back to the program.
Thank you, Professor de Vries. The next opponent is Professor Ruiter, Professor of Health and Social Psychology at Maastricht University.
Thank you, Madam Pro-Rector. Dear candidate, also my compliments, and also to the supervisory team for the very nice work. It has been quite a long journey. I read that you started in 2018, and then there were 2 happy moments in your life. 2 children were born. After that, there was already 1, but then COVID happened, that delayed, and then you had visits planned to Canada, which were delayed, and we were already referring to it before this meeting, that when we read the manuscript, it was quite some time ago. I lost it. I lost my questions, so I really had to check. So I hope I will make this. But I remember that, and it's also my feedback on the manuscript I saw back, and it was on chapter 3, but I will not ask questions about that. I also saw, by the way, that you have connections to 2 of my former PhD candidates, Dr. Charles Ejek, who is present here, and Dr. Fidelis Atibila. Yeah. Yes, maybe in the air somewhere, but hello, Fidelis. So you might have asked them what will he ask, and it might be about behavior change, and I'm sorry, it will not be. I've been supervising quite a number of PhD candidates from sub-Saharan African countries, and always cultural beliefs come back. And in this case, you're very explicit about it, because at some point you write, several points you write that older adults, they attribute their illness to witchcraft. And that's why they become sick, etc. And me, as a person being raised here, even in the northeastern part of the Netherlands, And we are not that, well, I don't know how to say it in English, but we call it in Dutch, be a bit too nuchter sometimes. But let me say very bluntly that I have big problems believing that they really believe that. And that's maybe also a sensitive issue, but I'm wondering, what are your thoughts about this? Is this the strong belief that indeed it's because of witchcraft, and you wrote that they attribute that, so it's outside their control, illness, or I'm thinking, is it not more kind of a defensive mechanism that people have here, that because of the difficult situation they are in, the environment that's extremely challenging, that they are somehow not able to see another way out than attributing this to things outside their control.
Thank you very much, highly esteemed opponent, for your compliments and also for your question. Well, for me, probably because I'm a health professional, I wouldn't believe that witchcraft or evil spirits affects me when I get ill. However, considering the literacy level of people, especially older adults who live in the slums, and also the society in which they grow up in, it influences what they think and how they think. So older adults in slums would normally feel it was somebody either in the family or outside of their family who is, in quotes, doing them. Yes, so that is how they put it. It is quite difficult to just on the face value shift that notion aside because it is inbuilt. So it takes a lot of sounding it every now and then to update their minds, to educate them on what some of these conditions may be caused by. And then, for example, if you take hypertension, letting them know is their lifestyle, their genetic buildup, that is why they are having that. With time, we can introduce their lifestyle modifications, and when things get better for them, they would come out or zip out of the thought that it is evil spirits. For some people also, they had hypertension, for example. Well, there was one person I met, and he never checked it. So then he had stroke, and he feels someone bewitched him, and he got that. But that wasn't the case. If he had done early reporting of his condition, it wouldn't have gotten to where it got to. So I think, and there's evidence to suggest that with frequent education, we would be able to get there. Thank you.
We'll be able to get there. What do you mean then?
Yes.
To counter their beliefs?
It will take time. It won't be a one-time thing, but gradually we should be able to get somewhere.
So you don't think it's a defensive mechanism?
No.
No, okay. No. It's truly built in, etc. Okay. Then I was wondering, you were talking about your mother, 102 years old, and I assume she was in very good health.
Yeah.
To reach that age. Where did she attribute her health to?
I'd say I was young then, so I probably didn't have this discussion we're having now with her. So I can't say as it stands what she would have thought. I know she grew very small. We could virtually carry her about. Meanwhile, she was taller than you and stout. Yeah, so I saw that change. But to say what she thought was her illness, no, I don't think I can answer that.
No, I wonder whether that's also due to luck or something like that, and then the opposite there, instead of evil, and that people have good means with her, or good and people are good to her, etc. But leave it. Now, what I would like to say, so if it's built in and it's not a defensive mechanism, how can we then work around it? And Professor De Vries was talking about Maslow's hierarchy of needs. I was thinking about a different theory, self-determination theory. Talks about intrinsic motivation and what makes people really strongly motivated to pursue certain goals. And I was thinking, and you made it also one of your points for practical implications, health promotion and awareness raising. And I also hear you talking about health education, but these sources of intrinsic motivation are autonomy, relatedness, and competence. Mm-hmm. And what I hear here back is that relatedness, you say family support is very important. You say, in terms of competence, you talk about health education, health literacy, improvement, etc. In terms of autonomy, I think that's also an interesting aspect here in this discussion, because I would say if we could strengthen people's autonomy, decision-making about their own health, their own situation, etc., it could also help them. Do you see possibilities there? What could be possible avenues to increase people's autonomy?
Yes, I see a possibility in increasing the autonomy of older adults as well as their caregivers. I think in one of our studies, we also realized that they were also very spiritual. So we recommended using the churches around to kind of win them. So when you go to a church and then you ask for space to speak with them, they revere the priest or the pastor. So it will be more of if the pastor has brought in a health person, then the pastor believes in what the person is saying. So that would also direct their thoughts towards whatever you say. So through that and motivating them to be able to take care of themselves and also be able to ask for help when the need be, instead of getting into accidents, that would also help. Yes, so the autonomy is needed. Yeah. Thank you.
No, I agree. No, so, yeah, I was also thinking about access to healthcare services, but that brings us to the nurses and probably to the question of the last opponent. Thank you very much.
Right, thank you.
Thank you, Professor Ruiter. Yes, we now come to the last opponent. It's Dr. De Boer, Assistant Professor at the Department of Health Services Research.
Yes, thank you. Well, first of all, also on behalf of me, congratulations on writing this very interesting dissertation, and also my compliments for the clear presentation you just gave, really good. And I would like to focus, a lot have been said on chapter 3, I would like to focus on the last chapter, so the qualitative papers, 4, 5, and 6, which I thought were very interesting and also very good to gather information from the different perspectives. And maybe I would like to start with a small question regarding the analysis that you've done in those 3 chapters, because I was triggered by the fact that in chapter 6 you write about that you did the analysis with another independent coder, or at least partly, whereas I could not find that information in the other 2 chapters, and I think that's a very good thing to do. So I was just wondering whether you could ensure me a bit more that, basically what you did in terms of the analysis in chapter 4 and 5 as a start.
Thank you very much, highly esteemed opponent, for your compliments as well as your question. Yes, for all the qualitative studies, analysis was done by 2 independent researchers. It was done separately. So one researcher reviewed the transcripts and then teased out the codes and then the themes and sub-themes. It's unfortunate that it did not appear in there. However, it was done. Yes. Thank you.
I'm glad to hear that. Maybe a question on some of the results, or overarching result, about the attitudes of healthcare professionals. In chapter 4, you write that some healthcare professionals seem to give preferential treatment in a hospital setting. I read it somewhere. And also in chapter 5, you say that professionals themselves told you that older adults from slums are not treated with a lot of respect, especially by nurses. And in chapter 6, I'm reading that, and also you told us just now, that students see older adults there. And I'm just wondering, can you reflect a bit on why is there such a negative in the first place? But also, is there a difference between the students and the healthcare professionals in the other settings, or is it just the first reflection on that, maybe?
Thank you. Yes, there's a difference between the students and then the healthcare professionals. Students who were recruited or who took part in this study had actually been to the health settings or hospitals for 1 semester. So they were at least 1 semester, so they were to report what they had seen being done or observed. In the study with the health professionals being interviewed, the health professionals were, in quotes, reporting those who were not nice to older adults. In the study on the older adults who said health professionals give preferential treatment, what was the scenario behind that had to do with older adults being in a queue, and then someone comes, and because the person knows the nurse at that point, that person is made to bypass the rest of them. Whereby in the case, had there been a structure and the queue was moving, the other person who came did not need to even bypass, but because he or she knows somebody, he's moved along, yes.
Yeah. So you're saying, well, the students were more positive, but they also had less experience in a way with the older adults or working with them. What do you think in terms of when they become healthcare professionals in a year or two? Will their attitude change then? Will they also get that negative or not?
That is actually the problem we realized. So we advocated for better training of these student nurses, because once they go to the ward, what they see is what they will do. So should they see nurses have a good attitude, it would influence them easily, because that is what they've seen being done. Whereas if they are seeing negative, it is likely they will transfer that, because that is what they see around them. So if we do training both pre and then after they are passed out, I think it will help the health system in general. Yes. Thank you.
Yeah. So you're talking about quite an extensive culture change as well, right, in terms of attitude change, and you're saying, well, training can be a solution for that before and after, but could you maybe give other examples, like what can we do or what should be done in order to achieve that culture change in general? So not only with, of course, with students, but there's a large group of people already working.
Yeah.
Can we do something there as well, and what do you propose?
Thank you. Yes, for those who are already professionals, suggestions were for, I don't want to use the word hit the whip, but for people to be queried, cautioned, if they do otherwise, as would have been expected of customer service. So if we have wellness workshops for these health professionals already in the system, gradually we would have a change in their attitude. Additionally, we've brought up the system of wearing name tags so that we can identify who did what, and then the query can be directed to that person. I think in practice, the Ghana Health Service also institutionalized the wearing of specific attires for specific cadres of nurses or health professionals, so that we can identify who has this behavior or this attitude, and then that person can be directed. So maybe more stringent measures on these health professionals would help. Thank you.
Thank you. Maybe I was in the discussion with the others, you were also talking about that the health illiteracy, or that people are not adhering to medical advice sometimes.
Yeah.
Does that play a role in also the negative attitude that healthcare professionals have?
Would say it does, because if they don't adhere, the health professional gets offended, and...
You want to finish your answer?
Yes, please.
Go ahead. Short.
The health professionals will get frustrated, and then they'll mete out these frustrations on others. So if they are educated and advised on adhering to required treatment regimen, that could also help. Thank you.
Thank you.
Thank you very much. Priscilla Attafuah, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Southside, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Get the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. To the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Please be seated.
Priscilla Attafuah. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Scholz is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
I first have to ask you a question. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority invested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Priscilla Yeye Adumoah Attafuah, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Okay. Dear Dr. Attafuah, dear Priscilla, congratulations to this wonderful achievement. The 4th of December will be a day you are never going to forget, and I speak on behalf of the whole team when I say we are all so proud of you achieving your PhD today. When writing this laudatio, I went back in my emails to see where this journey started. It was in 2017 that your colleague, also present here, Dr. Charles Ache, who was doing a PhD trajectory at Maastricht University, brought you into contact with Professor Jos Scholz. Professor Scholz read your research proposal and believed there was a fit between the topic and the expertise present at the Department of Health Services Research. It was at the end of that year that you crossed the ocean to set foot on Dutch ground and meet Professor Scholz and his colleague, Dr. Ruud Halfens, also present in the room, for the first time in Maastricht. From the very first moment, you had clear thoughts on what it was you wanted to do during your PhD journey. You wanted to focus on improving the quality of life of one of the most vulnerable groups in the world, older adults living in Canadian slums. I have to say that sometimes I was shocked to hear you speak about the circumstances of the people living there and to read about this. Pollution, violence, absence of accessible clean water, lack of sanitation systems, lack of healthcare, etc. In the Netherlands, we are quite good at complaining about the quality of care for our older adults. But for me personally, I think it's very good to hold up that mirror and realize in what world we are actually living. I have a lot of respect for you choosing this topic and wanting to contribute to improving quality of life for this group of people. Back to your meeting with Professor Scholz and Dr. Halfens. Jos and Ruud had a good feeling about your topic and academic skills and were willing to start this journey with you. They brought Professor Christa Loorman from the Medical University of Graz and the just recently graduated doctor myself on board. And together with Professor Aaron Abuosi, your local supervisor in Ghana, the team was complete. When I read back the proposal that you wrote in the end of 2017, something strikes me. It is not uncommon that research plans change during the years due to new insights or ideas not being feasible. And this is especially the case if new people come on board and have different ideas. However, your proposal is actually almost the same as the end product written down in your dissertation. And this means that you have either been very thoughtful at the beginning of your PhD trajectory about the relevance and feasibility of the studies carried out, or very persistent in the data collection phases. But this also aligns very much with one of the traits I value and I respect a lot in you, your tenaciousness. You have a very persistent determination. If you start something, you will finish it. You are not easily thrown off your game, and that's also what we've seen here today. You seem to be very calm and decisive, and I think this has brought you a lot so far. Back in Ghana, you started your scoping review on finding instruments that are used to assess quality of life in African countries. And I remember working on this with you together in the period you visited the Netherlands again, by scanning titles and abstracts and working through the full text. That was a lot of work, right? And it was often impossible to find the information on, for instance, psychometric properties or feasibility of applying the instruments. And it is clear that there is still a world to gain in this. After deciding which instrument seems most promising to evaluate the quality of life of people living in Teshi and Ashmayan, two Ghanaian slums, you went to the slums to collect the data, together with colleagues, and you managed to include an impressive number of 400 people. It was great to hear your stories about data collection as well. You told us that it was difficult to speak to people individually. Neighbors and other people living in the slums were often curious about what you were doing there. And as a consequence, it happened that whole crowds were standing around the other adult you were interviewing. So privacy was quite difficult to find. I also learned a lot from the studies you performed and about the creativity you had to display when collecting data. There are no structured lists with names and house numbers available if you do research in slums. You had to go from house to house and ask around if people knew other people above the age of 60. You needed a key informant to show you and your colleagues around in the slums, even ensure your safety, and help recruit people. You couldn't speak to everyone in the same language, as there are differences in languages between tribes. So this must all have asked a lot of your creativity and improvisation skills, but you never complained or came across as stressed. You just continued and finished the job. After doing the cross-sectional study, you also performed multiple individual and group interviews for the studies that employed a qualitative design. And for me, it is clear that collecting data is where your strength lies. You organize it, you do it, and you get the job done. Luckily, we're not all superhumans, and for the writing part, there were some struggles now and then. The distance between us also did not make this part easier. You visited the Netherlands again in 2019 for 6 weeks, and even though you were planning to come back in between, COVID and 2 pregnancies made it difficult to come to Maastricht. This made it a challenge to convert the richness of data you collected into publishable manuscripts. However, by meeting by Zoom on a regular basis, by working hard, and also because of your openness on receiving and processing feedback, that helped a lot. After receiving feedback, you always had a standard answer, which was noted, we'll work on it. And this, in the end, resulted in this beautiful dissertation. It was only a couple of days ago that you told me that you actually have a very personal reason to perform research on this topic. And I'm actually a little bit surprised, but also maybe even ashamed that I didn't know this before. Because your grandmom used to live in the slum up to the age of 102. Yeah. And you have an aunt who is 81 years old who is still living in the slum. And that's why you are quite familiar with this setting. You also told me that your grandma actually has a house outside of the slums as well, but preferred to stay in her house inside the slum. And this is a lively example that quality of life is influenced by various domains, on which the environmental circumstances is only one. Priscilla, I hope that your interest in aging, caring for older adults, and improving the lives of this population in Ghana will bring about the changes you hope for. Again, congratulations with this wonderful achievement, and I would like to congratulate your husband, Ivan, your children, Ruth Ann, Joshua Caleb, and Jonathan David as well, and also your parents who are present here on live stream. As I read in your acknowledgement section in your thesis, your dad asked you a couple years ago, wouldn't you pursue a PhD? Well, you just did. I have spoken.
Thank you.
Dear Dr. Attafuah, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. It must have been quite a job, I understand from what I heard today, and reaching the end of such a demanding adventure today must be for you quite satisfying, I think. I can tell you that also the committee here present was really happy with the way you defended your thesis, of course with your thesis itself, but that had already been looked at, but also with your defense today. And I hope you also feel satisfied with the way things have been going today. Because it's special to do a PhD defense here, coming here all the way from Ghana. But I really hope you enjoyed the experience and look back with a lot of satisfaction on this day. I would also like you to congratulate your supervising team with this beautiful PhD thesis on an important topic. Of course, I'd like to congratulate family, friends, small delegation here present, but the other ones probably online. With this, I think I will close this academic ceremony, and now it's time to relax and enjoy the rest of the day. What we'll do is we're gonna and Professor Loorbach, maybe you want to say something now to congratulate the new doctor?
Yes, Priscilla, I'm so sad that I'm not there